So, let's move on to just how do you document? So, when you're documenting a clinical assessment, and there is a free, form that it comes with all of my books. You can download it for free. I'll give you it's at therapythatworksinstitute/books.com. You just need to sign up, and you get all of the forms from all of my textbooks on one webpage. Um, but you want to be thinking about maximizing client confidentiality, and most agencies use a client number instead of a name. My goal is, I always tell my, supervisees, I want to be able to drop this, in downtown LA or whatever street, wherever city you are, let's drop it in the middle of the street, and your client's, identity is still protected. To me, that is a goal I've always had. In terms of using the numbers, in that way, because in the old days, they used to fall out of files. So if you're using paper files, of course, most of us are using digital types of formats. And again, just being thoughtful about always protecting client confidentiality. You'll, definitely want to be identifying what the clients say the problem is. So what's the presenting issue? What do they come in saying the issue is? Then using a mental status exam, usually a written mental status exam, to identify some of the major symptoms. And that can vary widely between, outpatient versus inpatient. Agencies are going to have very different looking mental status exams. And so then also a clinical assessment will typically have a diagnosis, an ICD or DSM diagnosis, and also a assessment for crisis and danger. So that's, suicide, child abuse, homicide, elder abuse, those sorts of things. So here is an example of the form, and I will give you, and can see here the URL is right there, therapythatworksinstitute.com/books. But you can see here you have the name of the clinician, you have the primary configuration, the primary language. This form was built for the US, where we have a lot of Spanish speakers. But normally you will identify, especially in family therapy, the age, the gender, ethno-racial identity, relationship status, occupation, and additional identifiers. This is really helpful, especially if you work in a context where you're under supervision, your supervisor's looking at a lot of these forms. This is really helpful in that sort of setting. And then also with children, age, gender, again, ethno-racial identity, school, and grade. And identifiers, so these identifiers can be things like religion, or health issues. But for children, I love to, put in their sports, their extracurricular activities. You can get a lot of information from that, especially as a supervisor when you're looking over these forms. Now, in these forms, they are designed to be used in training context and to train systemic therapists. So this one looks at, there's others in the household, in the family, or significant persons. So this can be, stepmothers, fathers, step siblings, grandparents, aunts or uncles, whoever's, real significant in the client's life. And then the identified patient for clinical assessment, this line is to have you specify who in the above is the person you are assessing in the rest of this form. And then you can see the presenting concerns. You can just check off the type of things, but this is what the client says that they're coming to get help with. Okay. So the website right here is the therapythatworksinstitute.com. People are asking about the about where to get these forms. Okay. So the mental status exam, you all probably learned, hopefully, how to do a mental status verbal exam when you in your diagnosis class. And what we're going to do here is to just talk about what's typically put onto the written clinical assessment that goes in the client file. And so there are ways to approach a mental status exam, both from systemic and postmodern, the two major schools in family therapy, where you are trying to get this information, but using systemic and postmodern approaches. So if you're using more systemic approach like strategic or structural or satir, You're going to be assessing the interaction sequence between all the members in the family. So let's say there's a panic episode, what's happening before the panic, as the person's panicking, the episode's starting to escalate, what's everyone, not only is what is that person's symptom, but what's everyone else in the system doing in response to their symptoms? What are the symptoms at their worst? And then what is everyone doing around to do that? And so you use things like circular questions, right? So who was the most distressed by by Susie's panic attack? Who was the least distressed? Who was the most involved? Who was the least involved? So this gives you a lot of diagnostic information for clinical diagnosis, but it also gives you a lot of information for your systemic assessment as well. And so from a postmodern approach, you will be, focusing on honoring the client's description and perception of the problem. And they have interventions within the postmodern approach, such as narrative, where they're mapping the influence of the problem on the person, on the influence of the problem on persons, and then the influence of the person on the problem. So for example, let's say there is a child who's been diagnosed with ADHD or is being assessed for ADHD, you'd be looking at how ADHD has affected the child in their life and what different contexts, at home, at school, with their relationships, with their siblings, with their teachers. And then, what I love, postmodern therapist turns this upside down, and then they're like, so how has the person affected the problem? How have they kept ADHD from ruining the relationship with their best friend or their relationship with X, Y, and Z? Or how does it keep them from, they're still getting passing grades in school? And how has this person been able to affect the life of the problem? So there are ways to still do clinical assessment, being true to the spirit of whatever your major theoretical approach is. And here is an example of the type of thing you would often assess, do a clinical assessment with. So interpersonal, conflict, enmeshment, avoidance, harassment, looking at mood, affect. So mood is what you're feeling internally. Affect is typically how mood is expressed. Looking at sleep, eating, anxiety, different types of anxieties that you can see here, looking at trauma symptoms, psychotic symptoms, motor activity and speech, thought, quality of thought, as well as social legal issues and behavioral issues, because tantrums, I'm seeing this right there. So something like this, you can click off a lot of the symptoms that will support the eventual diagnosis. So, so when you're making a diagnosis, right, a lot of what you're doing is ruling out other factors that might better explain some or all of the symptoms, such as a lack of sleep can explain if someone gets chronically not getting enough sleep, or, the days that they have anxiety is really related to the days where there's a sleep issue going on, then you want to rule that out and make sure you're addressing that before you slap some kind of diagnosis, some other mental health diagnosis on them. So, and so you're always in a process and you're constantly ruling out, and you can change your diagnoses. And also considering the ethical issues and consequences of what a diagnosis might mean. For example, there are, in certain military contexts, a diagnosis of depression will affect what types of roles you get assigned to. And so, being aware of that is always very important. And you always generally want to start with the least restrictive diagnosis, the least severe. Sometimes I see someone can take a diagnosis class and get really excited, right? And then, the first person they diagnose, they're slapping 4 or 5 different labels on them. I'm like, whoa, 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 slow down, slow down. And so the concept here is that you want to not give every diagnosis that sort of fits. It has to be the best explanation for what is going on. That means you've ruled off physical causes, and that this really is a good fit. And so there's, like adjustment disorders. A lot of people start off with adjustment disorders before they move on to something like generalized anxiety. You have to get the full history and the length of time. Yeah, someone is saying to a person with a hammer, everything looks like a nail. Yep, and you will definitely see that. There are a lot of people who have, favorite diagnoses, and they tend to see it. And the truth is, there's a lot of bleeding over. I'm really happy that there's a specifier that talks about depression with, with anxious features, because it's like, yeah, depression, anxiety normally go hand in hand. Okay, normally a depressed person has some anxious thinking going on, right? And vice versa, and often there's vice versa. So being really thoughtful and slow, especially to put on heavier diagnoses like a personality disorder, I think you really need to be an expert. Even ADHD, I like to get, a backup from a psychiatrist on that, or another medical professional. You want to be slow to give these labels, not quick, very slow. So this is kind of a worksheet almost in terms of helping you diagnose. It's checking off the things you thought about before making the diagnosis, such as age, gender, race, ethnicity, language, religion, social class, right? Immigration, sexual, gender orientation, cognitive ability. If you use the cross-cutting symptom measures, which are free with the DSM, you can see at psychiatry.org. You can check off which of the 13 scales they actually scored high on. And then you would list out the diagnosis code with the diagnosis and the specifier. And then it's a really good habit, especially in the first few years of learning how to diagnose, to list out the specific criteria. And so what criteria, open your DSM, look at the criterion required for the diagnoses. Which one did this client meet? This is a great exercise when you're getting started. And then also listing out the psychiatric and medical considerations in terms of, how you made the diagnosis and then what medications they are on. And then often in certain contexts for third-party payers to pay, at least here in the United States, you'll see you need to document they've met medical necessity, which means there's, either significant impairment or probability of significant impairment. And for youth, you can have probable developmental arrest for kids. And these are the areas of impairment. There are some places who actually want you to specify that as well. So another part of a clinical assessment, at least for most of us, is risk and safety planning. So this is looking at, risk of suicide, homicide, self-harm, violence, various forms of abuse, alcohol, substance use, and eating disorders. And then making sure you've put together a safety plan and making sure that you're tailoring it to each client's needs. There is, no harm contracts are often used around safety planning. There's different arguments for and against. Because another way to talk about it is what they call commitment to treatment, where there's some research that may indicate that rather than a no harm contract, having a client commit to 3 to 6 months of treatment can be more effective in terms of giving us enough time to kind of get out of the dark hole that a client might be in. So that's another way to also approach safety planning. Okay, so you can see here, and normally what you will need to check off in most organizations where you work is there's no indication or the client denies it, right? So you can see all the different various options here, looking at the history of sexual and possible physical abuse, other risk factors. And then it's good to always document indicators of safety. So what's going on that makes you think they are safe and don't, need to be hospitalized? And if you do have an element of, a safety plan, what are the types of things that are in it? And so you can use this checklist to document it all or help guide you if you're working probably in someone else's paperwork system. But this gives you a nice kind of place to start. Okay. Someone is asking, what's the percentage of clients' compliance with the safety plans? I don't know if I have a number on that, but obviously the vast majority do. And I think our goal is to make 100% of our clients compliant with a safety plan. And that really comes down to how you do it. The piece of paper is not what keeps them safe. What keeps them safe is the verbal emotional contract with you. And so you don't want to treat it like the paper's doing anything. It's really, it's almost a sales pitch with some of these clients to have them agree, like, I need 3 months of to, like, let's see where we're at in 3 months, and let's get that far. and so, or whatever it might be, depending on the situation. So it's the relationship that keeps them alive or not harming more than the piece of paper or the plan. Okay. Okay. Oftentimes too, depending what context you're in, case management will be involved. And so that's just looking at what other services might the client need to achieve their goals. And especially when you're working with, multi-problem families or clients who come from impoverished backgrounds, mental health alone, if they don't have adequate food and housing and physical safety in their neighborhoods, it's going to be really hard to make progress in terms of mental health. So you want to look at case management as the whole context around the client. Are all of their needs being met so that they can also achieve the mental health needs? So, so you'll have case management here. There is treatment planning that is often involved in kind of referring, getting people connected with these services and coordinating with other professionals. So here's an example of just, how you can document some case management. All of this is in the same form. Yeah, all of the, if you get my clinical assessment form from the therapythatworksinstitute.com/books, you have to give me your email so I will send you out new forms when new forms get created. You can get this entire form, and just for those of you who are savvy with their Word documents, and they are Word forms. And if you install, I'm not going to go into more detail than this. I'm just saying you can Google this. If you install the developer tab, you can also edit these forms. Isn't that really cool? But that's a whole workshop in itself, and I'm not going to add that into this. So let's see here. So, but you can see coordinating with professionals. Who did you talk to? Who have they been referred for a medical assessment, social services, group or other support services, forensic or legal, support as well. And then just looking at who their support network is. This is so important, whether you're working with individuals, couples, or families. Very important to think about the larger context, even beyond the family. It's like, who is the support network? And then, documenting outcome and prognosis. This also has a little chart for a client sense of hope. So it's a scaling question there. And there's a place to even allow the client to add some client perspective in there. And typically, if you're a student, you'll sign, and your supervisor will sign as well. Okay. So I'll go ahead and look at some of these questions. So someone is asking, does a client's diagnosis follow them if they see a new therapist? If you're in the same system, it definitely does. And in this world of digital documentation in health and mental health, increasingly every diagnosis is going to follow every client. And so it does depend on the company and their, if you're in a large integrated network, of course, everyone's going to see everything, right? But I will tell you, I just applied for some insurance, some health insurance, and they sent me like a 200-page document that had notes from virtually every doctor I'd ever seen. It freaked me out. I was like, how did you all get all this? It's really, I didn't have this information, but they were able to get it on me when I applied for insurance. So yeah, assume that what you're writing, especially if it's digital, it's going to go to any medical professional that they see. So I have a whole class on the 2-minute treatment plan and progress note, best-selling class I have. And my philosophy is keep it very medical, very lean, and do a medical progress note, because you just never know where these notes are going to end up. So that's a great question. So yeah, I do believe I answered the question about having the emergency and safety plan, all of that. Every form you saw here is in the clinical assessment that is free online. Lynn is saying here we have to be careful, especially when a lot of the symptoms are similar. Yes. Yeah, that's what, things like depression, anxiety, when you're in that genre of symptoms, it is, you do need to be careful. You need to proceed carefully before you give someone a label. In terms of getting the slides, I don't know if we give those out or if we have a system for giving those out. We're working on it. So at the moment, hopefully you get your screenshots. This will all post on YouTube. Yeah, and the website again is therapythatworksinstitute.com. In fact, there is a QR code for you. You don't have to type it out. How do you like that? So there's your QR code to get your forms. And just there's a little form on that webpage where you can input your name and your email, and it links you over to a page where you get all of my forms. Okay, very cool. Okay, so let's see. I'm going to go ahead and in the chat for those who are attending live, you can get your letter of attendance. It is the link is now in the chat box. Let's see. Heather saying Heather was saying she was part of my Laugh Your Way to Licensure and passed the national exam. Woohoo! I did. You know, we met on Monday, and I think all the letters went out on, or the emails went out letting people know whether or not they passed yesterday. So I got only happy emails yesterday. So congratulations, Heather, and to anyone listening who recently got licensed in my anywhere, whether or not you were in my course. So someone's not, oh, I see why you're not seeing a link. I can fix that. Hey, thank you for noticing that. What about that link? Can you see it now? There we go. This one to everyone. Let's see here. Okay. Woohoo! Okay, thank you, Robert. He's saying he did Laugh Your Way to Licensure and passed on the first time. Woohoo! We are hacking that exam in a sane way. So if anyone from the AMFTRB or BBS are listening, we just have the best test strategy, and we are learning how to decode those questions together. So yeah, we have a lot of fun in Laugh Your Way to Licensure. Awesome. Okay. So I see a question here from Priscilla. If I'm working with a family, do you need to complete one of these for each member? Normally, you just complete it for the identified patient. Great question. Normally, you'll just diagnose one person and submit that to insurance or third-party payer for billing. But yeah, you would just do this for one person. That's why you'll see on the family version of this form, you know, it says who is the identified patient from the family system. And there is a counseling version of the form where it's clearer that it's just the one individual that you are seeing. But even on the counseling version, I have people put in all the significant others, just because it's really important. Sometimes I sit down with my students, they've seen clients for 2 months and they don't know who's in the household. You know, understanding the family system is actually more important when you're working with individuals, because they're not in the room representing themselves. So it's really important to get that information. But great question. Yeah, you just do one usually per person. Awesome. Okay. Let's see. I noticed that there is a checkbox over. I see the forms, but I noticed that there is a checkbox for emergency contact card and things like that. Is there a template? I don't have the emergency contact, actually. This is more what you're going to put in the file. The emergency contact is more what the client's going to fill out at the beginning, is normally where I put it. And I have an online system where they input it. So it's not in these clinical forms, which are really more intended for educational purposes. Awesome. Okay. Let's see. Okay. If you're on the website, you go to, this is where you're going to get your letter of attendance, and I will go quickly and pull the book. So you go to the Therapy That Works Institute, go to books, and then for professionals, you will see that there is a free clinical forms and resources page. And that is where you put in your email. Tell me whether you're a student or an instructor, whether you like counseling or MFT theories. And then thank you, Katrina. Wow, I got support here. I love it. And that way, you know, when I update forms, you're on a list to get that information. So that is why I take that information, since I do have people using textbooks and using these forms. When you know, if something's wrong with one of them, I will let you know. So awesome. Okay, how do you draw the line between a diagnosis for the IP within a system and the appropriate response to dysfunction of the system? You know, it's constantly balancing, Nicole. It's a great question. You know, it's constantly balancing the both and. I try to go as strength focused as I can, especially, you know, with everyone. Oh my God, everyone's so stressed these days, right? So I try to be as strength oriented as I can with people. And even with the system, with the person who has the symptoms, and looking how if your partner or your child or your parent has a mental health symptoms, let's just say, let's even forget the diagnosis, how do we find compassionate, humane ways to work with our family members and our loved ones in a way that helps everyone go forth and be better human beings and work together to navigate these issues. So it's a both and. I normally really shy away from saying anything's fully physical. It's 100%, I mean, biologically caused, and instead looking at how can we make shifts in the relational or other context variables to help make things work better for everyone in the system. Are there family systemic assessments that I recommend, such as the score? All what I use in my practice, I only use two assessments, I'll be honest. I use the DSM-5 cross-cutting symptom inventories, the level one. I use it with all of my clients. They fill that out. Yeah, so I have all of them fill that one form out. It takes about 1 to 2 minutes, right? So it's not too much to ask, but I have every adult and child who comes through fills out one of those cross-cutting symptoms. That you'll find that, just Google DSM-5 cross-cutting symptom measures. It's on the American Psychiatric website, and you can download all of those. They are free. They actually have level 2 ones that help you identify mild, moderate, severe. And then I use the dyadic adjustment scale, and everything else I do verbally in session and through observation. I'm old school, man. That's just how we did it back in the day. So that's what I use, is dyadic adjustment scale for couples. It kind of gives me a sense of where we are starting as couples. Family is pretty easy to assess, in my opinion, so I don't feel a need to have that. The couple one I find useful. I just know where the hot spots are before we start talking, and I find that useful. So, how much of my assessment do I share with clients? That's a great question. I would say I share as much as I think will be helpful to them. I'm very slow to share if I'm thinking like personality disorders. I rarely find that clinically useful to them. I rarely put that down into, I won't do that I'll let a psychiatrist do that. I will conceptualize those, but the rest of them I will talk about it. I'm seeing major depressive disorder. This is what the DSM says. What do you think? Let's have a conversation. Does that fit for you? Do you agree? Do you disagree? What does that mean when we say that? Is it helpful? Is it not? And I try to help them come up with even an internal dialogue or an understanding, whatever the diagnosis is, that is liberating, helpful, and helps them become feel better about themselves and their situation. So it depends on the client, but I'm always intervening. I never just talk about diagnosis without realizing every word you say around diagnosis, you are shaping the possibility for moving forward. And so it's more intervention than anything else. And if I can't see a way to describe it that isn't going to move us forward in the quickest path forward that I can see, I will I will think about how I'm going to talk about it until it's really useful to the client. Someone saying they thought they can't diagnose, you might be in a state where those privileges are being questioned, or I don't know if there's a state where it's taken away. Certainly in California, we can diagnose. I know in New York, there are some changes to those laws. You have to get special training to diagnose. But in the majority of states in the United States, we can diagnose. The majority of us can. Okay, awesome, awesome. So hopefully you got your letter of attendance if you needed it. Let's see. Okay, common factors family progress note. Okay, I'll have to think about that. Awesome, awesome. Yep. So Drina is saying she uses one goal for the patient, one for the family. I often have yeah, individual as well as relational goals for all of my clients. Thank you. Awesome. Everyone's saying thank you. Thank you. Okay, folks are going to go see their clients. It is the end of the hour. I am so glad you all enjoyed this course. Yes, if someone needs a medication, you definitely refer them out. I don't know of any MFT who legally is allowed to prescribe medication. You all are awesome. Thank you. Oh, thank you for all the hearts and clapping. I love it. Love it. Oh my God, more and more things are coming in. Oh, someone wanted to know what assessments I use. I use the DSM cross-cutting symptom measure, level 1 measure. It is free from the American Psychiatric Association. Just Google APA, DSM, cross-cutting symptom measures. And I use the dyadic adjustment scale, and you can find that for free as well online. Is Laugh Your Way to Licensure good for people with ADHD? I would think so. It's one of the only ones that have the video. It's fun. I keep you entertained. It's as fun as you can make it. Now, it is not stand-up comedy, okay? But it is as fun as I think you can make it. Awesome, awesome. Good to see you, Erica. Everyone, thank you, everyone. Yay, everyone's happy. Awesome, awesome. Well, I wish you all the best, and we're continuing. There will be a another one on progress note writing and treatment planning. So we will see you soon. Yes, APA DSM cross-cutting symptom measure. You got that, Megan. Okay. Okay, Brittany, I don't know what your question means. When do you recommend starting the course? Thank you, Katrina. You were like my assistant today. She's got the DSM symptom measures here in the chat for you all. Oh, the Laugh Your Way to Licensure course, I would start 6 to 12 months before you want to take the exam and do it as close to graduation as you can. So, and you can buy it, we renew it until you get licensed. So, and you can come to all the live coaching as long as you're enrolled. Okay, well, have a good evening. Yes, especially in Egypt. Thank you for staying up. Awesome, everyone. Thank you, Megan, for the shout out for Laugh Your Way to Licensure. We are making MFT licensure easy. But you all be well and take care. And you should be getting emails about when this posts on YouTube, so you'll have access to it long term. Be well and take care. Bye-bye.